Good morning, everybody. My name is James Simoes, and I am here on behalf of Protect Our Care New Hampshire with a really amazing panel who's going to help us break down some of the headlines over the last few weeks and maybe take a look at where New Hampshire is going over the next few months. So I want to thank everyone for joining us in this discussion today of what comes next. I just want to start by saying that here in New Hampshire, Medicaid and the Care Act are not simply um, a safety net, but they're a lifeline that supports community health centers, keeps rural hospitals open, and ensures that families can get the care that they need close to home. But today, that lifeline is in real danger. Thousands of Granite Staters are at risk of losing coverage. Clinics, hospitals, pharmacies will close. Health insurance premiums could rise by as much as 70% next year. And staffing shortages, maternity care gaps, limited rural access are threatening to push our state's healthcare system to the brink. So this morning we're joined by three New Hampshire experts who will help us to understand these changes, what they mean for patients, for small businesses, and for our economy. I want to welcome Phil Sletton, who is the research director for the New Hampshire Fiscal Policy Institute, Ed Shanshala, the Chief Executive Officer of Ammonoosuc Community Health Services, and Christin of Putney Consulting. All of you, welcome back. We have been having this discussion for a while now, and I think you've all helped provide context to our listeners. I want to start with you, Phil. A lot has happened over the last 6 weeks. Would you mind just giving us a bird's eye view of what's going on right now? What do we need to know in terms of these changes?
Sure. So in New Hampshire, there are two significant pieces of legislation that have affected the structure of Medicaid, or at least how a lot of people will interact with Medicaid in the state. One is the state budget, which was signed on June 27th. And then, of course, the other was the federal reconciliation bill, sometimes called the One Big Beautiful Bill Act, that was signed into law on July 4th. So these two things happened at about the same time. Both of them affect Medicaid in New Hampshire substantially and how people access coverage in New Hampshire substantially. On the federal side, the law was actually mostly a tax law. It reduced taxes by about $5.4 trillion over the next 10 years and reduced expenditures to offset some, but not all, of those lost revenues from the tax reductions that were either extended from prior law or new tax reductions that were put in temporarily. Those expenditure reductions were particularly large in Medicaid. There are a couple different estimates out there, but between 900 billion and $1 trillion in reduced expenditures on Medicaid over the next 10 years would be expected relative to what was the prior policy baseline. And there were also reductions to food assistance and energy subsidies and a couple other areas as well as some boosts to military expenditures and immigration enforcement expenditures. So, focusing on Medicaid and the impacts on Medicaid in New Hampshire that we can expect, there were work requirements that were enacted into law associated with the federal reconciliation bill, or enacted by the federal reconciliation bill. And this is new for Medicaid. There are some states, including New Hampshire, that had tried Medicaid work requirements in the past, but federal courts had generally said Medicaid is not a program that should be requiring work. It is a health program. And that's me paraphrasing, right? Not being a legal scholar here, but that's the general upshot. That requirement now changes, or that stipulation of the Medicaid program now changes because there are federal work requirements in Medicaid that states will be required to follow for adults in certain situations, and these are adults who are generally in the Medicaid expansion population, although it's a little bit broader, a little bit more expansive than that, and does affect at least two states that don't have Medicaid expansion. New Hampshire is, of course, one of the states that has Medicaid expansion, the Granted Advantage program. So New Hampshire will be required to implement those work requirements for the Granted Advantage population, which is a little less than 60,000 people enrolled in Medicaid currently. About 20,000 people would be expected to be disenrolled based on the projections that I've seen from those Medicaid work requirements in New Hampshire. So, a substantial portion of that 60,000 people. And there are also impacts on how the state finances Medicaid. There are limitations on what are called provider taxes, particularly for hospitals. We in New Hampshire have the Medicaid enhancement tax at a rate of 5.4%. It will be limited to 3.5% starting in October of 2031. Now, it's really wonky, but what that means is that one of the key ways that the state raises money to fund Medicaid will be reduced, will be limited, which means the state will either have to find roughly $133 million in more revenue, or that's the amount that would have been the amount less that would have been raised in fiscal 24 if that tax rate limitation had been in effect. The state will have to find, a large amount of money each year that it doesn't currently raise to fund those services, or will reduce funding and reimbursements for Medicaid because of that limitation on provider taxes. There's also some limitations on who's eligible. And there are co-payment requirements. So certain legal immigrants, for example, who are currently eligible for Medicaid would no longer be eligible. There are also the co-payment requirements also mean that people will have to pay more to access Medicaid services. And that is both a hurdle for those individuals who are looking to access care and also an administrative barrier, right? It's an administrative hurdle for the state to be implementing that because, again, this is a state-federal partnership, the Medicaid program. And it's worth noting, too, the state will have some impacts that are fiscal impacts from food assistance reductions and from some of the energy subsidies that will probably affect state fiscal policy to a certain extent, particularly on the food assistance side. But if we just look at Medicaid, this is an estimated $2.3 billion less in federal Medicaid expenditures in the state over the next 10 years. Now, on the state budget side, which remember passed just before the federal reconciliation bill was signed into law, there were also Medicaid work requirements that were that were requested in that, as well as Medicaid premiums. And we don't have complete clarity yet at this point, but the Medicaid work requirements may be superseded by the federal work requirements. They are somewhat different, but they may also be permitted by the federal government through a waiver. That's a possibility, at least to my knowledge. The premiums, it seems as though the state may not be allowed to institute the premiums, but would be required to institute the copayments. But again, there are still some key questions on that point. So those two pieces of legislation, not only did they make changes themselves to Medicaid, but they're also going to be interacting. Some of that still has to shake out, but it's likely going to be fewer people enrolled and less Medicaid expenditure in New Hampshire over the next 10 years.
So I think complicated would be the word to describe what you just said. And I'm going to come back in a minute with a question like, how are we going to implement these work requirements? But first, we had a journalist who, and thank you, I see we've got some media on the call, and we're very grateful to have you here, um, put in advance. And it's a really good question. So I thought we'd start with it, which is whether the changes are more significant for critical access hospitals or could they, I'm assuming they mean the critical access hospitals, make out better given the $50 billion in rural health in the federal bill? And I put that out to the panel, whoever wants to answer it, because that's a interesting and also complicated question.
I can reflect on it from a North Country perspective, from a couple areas. It is a one-time limited funding. This is not forever. It's expected to cause some form of transformation in rural healthcare. I'm not certain what is meant by that. And so it will run out. So in and of itself, it appears to be recognition of the law that was passed, concerns about damage being done, yet not recognition to the point of making sure that the damage done isn't resolved in a more permanent, continuous way. It does focus more on critical access hospitals that are important and is relatively silent on nursing homes in the county level, community health centers, mental health centers. There's a silence in that broader healthcare system. And there's some talk about loopholes that some of those funds may be diverted because of a loophole away from rural health centers. So not as it limited in time and money, the money may actually be less. So I look at not just at Ammonoosuc's perspective, but how does it affect the care access for patients in emergent long-term care, home health and hospice, nursing home care, and the like. It's a bigger concern I have.
Anybody else want to jump in on that?
Yeah, I'll chime in just quickly relative to the, as Ed noted, it's supposed to be transformation. It's called the Rural Health Transformation Program. The fund will distribute about $10 billion over the next 5 years. Of course, this bill affects expenditures over the next 10 years and has some permanent changes to law as well. The first half of it will be divided equally among the states, at least states that apply for it. And the second half of it will be very much up to the executive branch in terms of exactly how to administer it. There are requirements for how states apply for those funds and what they have to include in their applications, but the actual distribution will be very much in the hands of the Centers for Medicare and Medicaid Services. The law that the legislature wrote empowers the executive branch to make a lot of those decisions. So we don't have a clear understanding of exactly how those funds will be deployed, the breakdown of rural areas to non-rural areas. So there's a lot of flexibility that the government has in deploying these, at least half of these $50 billion. Now, I do want to note that KFF, the healthcare nonprofit research organization, identified that the $50 billion would be about 37% of the estimated reduction in funding for rural areas from the federal government for health services over this time period. So $50 billion is a lot of money by any measure, but it is significantly less than the amount that at least KFF estimated would be reduced in terms of funding flowing to rural areas through the prior Medicaid structure.
Well, thank you. I wanted to then roll back to something you brought up, Phil, which is, based on these newly passed state work requirements. This isn't something that other states or New Hampshire have had a lot of success in figuring out. I think it was Arkansas had tried it, New Hampshire had hypothesized it a few times. Any idea how this will work, how it could work? Because it seems pretty complicated, but then who's going to be the most affected by these changes in terms of our neighbors here in New Hampshire? And I put that to the panel.
I'll say a little bit about the prior experience that New Hampshire has had with Medicaid work requirements. New Hampshire has not. So right now, Georgia is instituting Medicaid work requirements, but doing it in a way that is actually for people who are entering the program. There's additional services offered for people who meet work requirements. And there aren't actually very many people who have gotten through the application and verification process for that expansion to Medicaid in Georgia. But the prior experience that we've had that will be more akin likely to what we're going to see from essentially required by the federal government is that Arkansas did have an effort to require work requirements for certain enrollees. New Hampshire did as well. New Hampshire was a little bit behind Arkansas in terms of implementation. Arkansas had started having significant disenrollments, had made efforts to reach individuals to get documentation of work being completed to fulfill the requirements, and had not been successfully reaching folks. In New Hampshire, we didn't have any disenrollments because there was a safety valve, if you will, in the program that essentially allowed the state to cease implementation of the program if it was going to lead to significant disenrollments. The state had determined about half of the Medicaid expansion population, which was where this was going to be required. The work requirements would be the half the population was exempt for one reason or another. And then of the other half of the population, I think about 24,000 people, almost 17,000 people would have been disenrolled or started to be disenrolled because there weren't, despite significant outreach efforts from the state, there wasn't completed paperwork. People had not heard of the requirement, did not know that the requirement was something that they had to comply with, and essentially the state had not gotten a response from them. We have other data, there's other survey-based data that do suggest that most adults, or at least the majority of adults on Medicaid, are working, and most who are able to work and don't have some other barrier to work are working. But the administrative both costs and burden on both the state and on individuals is likely what's keeping a lot of people in past experiences with work requirements, including in New Hampshire, is likely what's keeping a lot of people from fulfilling those work requirements on paper and then remaining on the program.
Anyone want to add anything else to that? All right.
I mean, I think that I'd like to add that we know that people are trying to meet requirements, but when barriers are put in their way and they already have, problems accessing care, or accessing an office, or you have to make a decision between applying for a job and going to a meeting and filling out things online and with paperwork, it's not easy for people to do that. That people will do the most necessary needed thing. And if that means giving up the coverage that they have, or if they have to make a decision between putting food on the table or doing something else with their funds, like their own health care, they might just, put food on the table. And so we're just forcing people to make decisions that are really not going to help anybody. Well, except for those that benefited from the big, beautiful bill, maybe.
Right. And
just to add to what Christine said, she's absolutely right. And as an example, our no-show rate is relatively low at about 10 plus or minus 2 percentage points, which is actually really very good in the marketplace. And one of the things I realize is that in a gig economy where you're making snow on Cannon Mountain, or you're a bartender, you're a waitress, you're working for a landscaper, when you get the phone call that says, can you come in for a shift at your favorite restaurant, but you have an appointment scheduled, you have to go to the restaurant. And so by digging behind that, I'm like, that's unfortunate. And I understand how you made that decision, which puts us in a position of how do we help this population balance access to healthcare given the dynamics of a fluid workplace. And if they didn't go in, maybe they don't get called next time, right? So to Rachel's point, if they drop the Medicaid and we follow that person through the system, they may not get the breast and cervical cancer screening. They may not have their diabetes in control. We may never catch the fact that they have hypertension. And we do that at a national average of about $170. Now they're at the hospital. Based on MEPS data, that's $750 to $1,500. If they have to be hospitalized in New Hampshire, that's $2,000 a day. If it's ICU, it's $11,000 a day. It's expensive, it's a bad outcome, and it's an outcome that could have been prevented. And now it adversely affects the economy because that individual who got called into a shift, if they're in ED, they're not answering that call. Now that place is short-staffed. So you start following the people through the system and the money. And in all probability, the person now doesn't have Medicaid. They're uninsured. Now you drive up bad debt. Bad debt goes back to commercial insurance premiums. So if people think that I'm not medicated, let me help you understand the impact of the broader system, that even though you're not Medicaid, I don't understand how this affects me. That's a way. You don't get served at the restaurant. You wondered why. Your health insurance premiums went up and you wondered why. Part of that is the taxes break for that small percentage of people. They got their money, you got the consequences.
And that's really well put. And that actually brings me to my next question for the group, which is we've got a couple things to look at here. We've got these cuts to the extended tax credits for the ACA, which haven't been renewed, which will impact a lot of people in New Hampshire. We've got the cuts now to Medicaid, the changes to Medicaid in terms of a work requirement that's not particularly well defined. And just this week, we read that Cigna, which is a major healthcare provider in terms of insurance, is saying that they may have to cut CMC, which was recently acquired by HCA, a lot of initials, but CMC is, of course, in Manchester, the largest city and the largest market in our state. There's a lot of access issues here. How are all these things, looking ahead into the future, going to impact rural clinics, hospitals, maternity services in New Hampshire? And what's the economic fallout for a state that is aging rapidly, having issues with staffing and filling jobs, but also attracting new businesses and new residents? It all seems to come together. If we look into the future and we're on this track, where's it going to lead us? And I put that to whoever wants to answer it because it's not a question I want to answer myself. Kristen, you want to go first on that fun one?
Sure. I mean, I think it's so, what Ed was saying, there is a web here. It's not one thing that impacts one person and it doesn't impact you. Everything is a network. So if we want to talk about maternal health, right, we know that in New Hampshire, women are more likely to be enrolled in Medicaid. We have a good chunk of the population that are. So, cuts in service are going to have a greater impact on them and the children, right? And when people already have a hard time accessing care, especially in rural areas, we see closures. So then people can't get maternal and perinatal care. And so they have to travel farther, and we see poor health outcomes. Women and children suffer higher depression and anxiety, and they're more likely to seek care for that. So if we have closures, then there's less access to care. If we have less people that are available to access coverage, they don't get the care anyways. And according to New Hampshire Women's Foundation, behavioral health, including substance misuse, is the leading cause of maternal mortality in New Hampshire. And in the past 2 decades, 11 maternity wards in the state have closed. I mean, I think it's that alone, that population, looking at that, it's pretty clear.
Yeah, she's absolutely right. And I came in 2005, and in 2006, around that time frame, Weeks was not able to continue delivering babies in the Lancaster area. A few years later, Cottage Hospital was no longer able to deliver babies. So if you want to deliver babies, you have Littleton Regional. To Plymouth, you have Spear. If you go north, you have Androscoggin and Berlin, which is the only place to deliver babies in Coos County, a county of 50-some thousand residents. So to your point of, I need to hire staff from the $20 wage earner through the physician who may be delivering babies, but doing primary care, prenatal care. I need to hire behavioral health providers to staff our K through 12 behavioral health program. Where am I going to live? That's a challenge. It is 0.6% vacancy in rentals. So that's part of the conversation. Where am I going to deliver my children? Where do I get access to healthcare, regardless of what type of healthcare, are important questions. And whether it's a county nursing homes, it's a critical access hospitals, community mental health center ourselves, we're going to be hiring people who are in a younger age group in their 20s and their 30s are starting to have families. Berlin's population is tipping down. Littleton's amazingly has tipped up a little bit. So that's actually, there is a little bit of good news in the community. So Kristin's absolutely right that the longer the distances, heart attacks and strokes, you've got about an hour. There's a golden hour in there. And even the ambulance services, Easton no longer has ambulance. Franconia doesn't have ambulance. Warren, New Hampshire just lost their ambulance service. We can't afford those waits and delays. It's going to drive up. People are not going to do as well when they present at the hospital, or they may not make it. And now you're off to the funeral industry, which is preventable.
And Jaime, I can speak to the macroeconomics briefly. So I mentioned that $2.3 billion figure. That's how much fewer federal Medicaid dollars would flow into New Hampshire over the next 10 years based on early estimates from KFF. That is roughly the equivalent. It's slightly less than the amount that the state and federal government spent on Medicaid in New Hampshire in fiscal year 2024. So it's basically taking a year of total Medicaid expenditures out of the next 10 years. Again, you got to think about inflation. You have to think about, how many people are being covered. Medicaid is the single largest program that the state operates in dollar terms and reaches about 185,000 people currently, and provides access to health coverage for those of us in the state who are on Medicaid. So that, has an effect then downstream of what does it mean for hiring healthcare employees? What does it mean for funding services and allowing services to stay open and operating, allowing providers to stay open and operating? What does it mean for the state fiscal policy decisions that are made that, may, for example, if the state could raise additional money and look to find ways to fill in some or all of that $2.3 billion in offset in lost federal funding coming into the state. But then there are questions about what are the trade-offs in other services, or what are the tax or fee or other revenue sources that the state would have to raise to bring in those additional dollars. And I do want to note, I mentioned that this was primarily a tax law at the federal level, and every household, well, every income bracket of households would see a tax rate or tax reduction in aggregate as a result of this law passing, as opposed to if it had not passed. However, if we look at the aggregate amount of resources that go to households, so that's Medicaid, food assistance, taxes, tax credits, right, and look at the changes across all of those. The Congressional Budget Office estimates that for lower income households, it's a reduction in resources, and for higher income households, it's a pretty substantial increase in resources as a result of the federal reconciliation law. And we know from economic modeling and economic theory that more resources going to lower income households is more economically stimulative, because those households spend those resources or use those resources in the economy and to collect goods and services that are needed as a higher percentage of the resources provided than for higher income households. For higher income households, it's more likely to go into savings or investments or something else that maybe goes out of state, as opposed to local resources into a local economy. So there's all sorts of macroeconomic trade-offs on that front, but this is fewer federal dollars coming into the state, and that probably has cascading implications.
And I want to say thank you for that, because that's an important thing that we can't forget, that we're cutting healthcare service to working families to benefit wealthy individuals and corporations with tax breaks. I know that we've got a question from the press, and I'm going to ask my colleague Rachel to join us, and we'll have her ask the panel. Hey, Rachel, good to see you.
Thanks, John, and thank you everybody for joining us today for this conversation. For our press who have joined us today, if you have questions for us, please drop those in the Q&A box at the bottom of your screen, and we will be monitoring that. And yeah, like Jaime said, we have our first question from Mira Mahavedan from the Granite State News Collaborative. Thank you for your question. And that is, could you please talk about what kind of impact that federal cuts to SAMHSA, which is Substance Abuse Mental Health Services Administration, under RFK Jr.'s directive to close that agency and fold it into a new organization called the Administration for a Healthy America. Could you please talk about what this means for mental health services in New Hampshire?
I can speak briefly from, we've integrated behavioral health within our federally qualified health center. That funding comes through the Health Resource Services Administration, does not come through SAMHSA. However, we have community mental health centers that are critical for people who have more severe mental health concerns that need to be addressed than what we're able to take care of. We do not staff psychiatrists. We staff psychiatric nurse practitioners and master's prepared licensed social workers and mental health counselors. So to the degree to which those SAMHSA funds and that go to my community mental health centers, who are already struggling economically and staffing, that will not be a good thing. Part of my concern in the consolidation is to the degree to which we lose the technical expertise in mental health and in psychiatry at the federal level. My experience working with federal employees is that they're very knowledgeable. Their personal values match the visions of the healthcare providers, regardless of mental health, critical access, or an FQHC. So when I hear people say, I don't like the government, I'm confused, and I'm not understanding, you need to be more, I need to ask some more questions. My experience has been very helpful in our delivering our mission, and been very helpful in delivering the mission on technical expertise for places like our community mental health centers. So it gives me some concern. It's I don't know yet. I'm not certain that's a good thing.
I think too that, how smooth will the transition be between these two agencies? Will there be a gap when small organizations, there's a whole prevention, treatment, and recovery network that are small local coalitions. They're going to have a gap in their funding that they rely upon to exist. Those people are going to potentially have to close the services they're doing. No one gets that treatment, care, connection, whatever they were providing. Those other people have to go look for another job. And that organization may never recover again just because of that small gap in their funding source, because, money's moving around and now this person's in charge. And, also applying for SAMHSA funding is not an easy thing to do now. Maybe they can make the system more easy, but right now, applying for federal funding, it takes a lot of skill and experience in just doing that piece. So I can't see that it's going to help anybody.
And just saying, Christine said, I want to step back out and remind people that Governor Sununu established a recovery-friendly workplace within the auspices in New Hampshire. We at Ammonoosuc are. And so when you think about work requirements and what's happening to SAMHSA, it gives me some pause of, we are very receptive to working with a variety of people who present to us to be employed. And if you're in recovery, that's great. We're providing you that work. But if you don't have those supports out in the communities for you to be successful, it gives me concern that a person could slip out of recovery without these resources, and maybe they just don't come to work anymore. So that those unintended consequences really require some thoughtful case analysis, some tracer. Follow the person through the system, follow the money through, and ask good questions. That if you're trying to be more efficient, you also have to be effective. You can't do one without the other. And it's easier to do the thought experiment on paper than do it in real life and damage people's lives. That's hard to undo. That would be my concern with what's going to happen with SAMHSA, is the lack of transparency. And are you considering that there's a human being at the end of this in all of what we do? And we can't forget that.
Well, thank you, Ed. And thank you, Kristen. And thank you, Phil. This has been a really useful conversation. I mean, my takeaway is, we have solutions within our reach, but every day we delay, we're putting patients, providers, and our economy at a greater risk. And, we can't afford to wait, until the damage is done to fix the problems that surround us. We're going to be back in a couple weeks, so we're going to hopefully go live in Littleton, which will be exciting on this Protect Our Care New Hampshire podcast. We still have a lot to talk about. I wish we had more time. I want to thank the panel. I want to thank the media folks who joined us. Discussion continues, and I think this insight helps us know where we're going and hopefully come up with some viable ways to work around the roadblocks that we're facing. So thank you, everyone. It's been a real pleasure. And thanks to your help, Rachel. Thank you. See you next time.